You call, we haul, that's all.
Did not get transported. They did not get
As
paid.
if you're my own mother, father, brother, sister. That's my job.
I've been doing this for 20 years, Dr. Moy.
Right. It's unfounded. We don't get paid no matter what. We are adrenaline junkies. We're in emergency medicine. We're in EMS.
Tune in for today's episode of the Leadership Lab, Clarity Special Edition.
Thank you for joining me for another episode of the Leadership Lab with Asbel Montes. This is our special edition series because we are recording these podcasts from our 5th annual user summit in beautiful Laguna Beach, California. And so I was able to capture a lot of our guests that were speaking to us about data, doctors, and leadership through the eyes of the patient. If you watched a previous episode that I had with Dr. Cozy, he gave me the idea about the through the eyes of the patient, kind of a general thing that we had done a few years ago. So it was kind of a reminder to me as we talk about data, doctors, and leadership. So we've got a lot of doctors here. And so, Dr. Moy, it is such a pleasure to have you on this episode of the Leadership Lab.
Well, thank you for having me. I'm very flattered to be on.
I'm glad you're here. So to our audience that may not know who you are, Dr. Moy, and tell them about your podcast, because you got a podcast as well, so we're going to give a plug out to that. But give us a little bit of an inside look into Dr. Moy.
Well, first off, this podcast studio is a lot more extravagant than what I have, but this is phenomenal. My podcast is the Air Methods Prehospital Education Podcast, which really has to do with educating my pre-hospital clinicians, be it flight, ground, or even the lay public, about what clinical problems we face in the field when dealing with patients. And I got my start in kind of healthcare. I spent 12 years, 4 years of college, 4 years of med school, 4 years of residency within 4 walls, basically the library, the med school library, or the hospital. Right. And that was kind of my life, and that was my world, my bubble, as I call it. And then in my residency, I did an EMS rotation, right, where you ride out with medical directors as well as paramedics of your local EMS agency. And I like to refer to that as like, hey, you know what? There's this whole other world outside the hospital called the real world. And that EMS rotation was a master class in reintroducing me into the real world, but also a master class in seeing social determinants of health, where my patients come from, how they lived, how they breathed, and how they struggled. And it really showed me that emergencies, while they do happen randomly, they're actually, a lot of it is a culmination of issues like economic instability, health illiteracy, social issues that kind of cascade into a explosion of what we call emergencies. And during that EMS rotation, I realized that EMS is more of kind of a Venn diagram. It's an interesting, I would say, field of medicine because it's an overlapping of public health, public safety, and medical care. And EMS sits right in between there, and just gave me a really different view than just practicing in the emergency department. And I began to see the gaps and the holes in the healthcare field for our patients. And I began to see that maybe our EMS systems should be more than just a fancy taxi cab ride to the hospital. So I followed that curiosity into an EMS fellowship in University of North Carolina. I met some phenomenal mentors, Dr. Bryce, Dr. Myers, Dr. Cabañas, and that really solidified my view of what EMS could be, which is a not only reactive healthcare model, but also it can be a proactive healthcare model to fill those gaps in healthcare at the patient's doorstep because it's got all the logistics in place already.
Well, I love it. So the story is that you have gotten more involved as a physician, and we're kind of talking about the theme of healthcare payment finance reform.
Yeah.
And so how we could go away from being a transport model, reactive, to now how could we also be proactive? And that is what started you on this journey.
Right.
There are some things that you did not bring out that I know about you, about some of the stuff that you're doing on the national level, some stuff with associations, namely the National EMS Physicians Association.
Yes.
Or what we call NAEMSP. We have 500 different
There's a lot of NAEMS somethings out there.
Let's talk a little bit about what you're doing there, what that looks like, and then I want to dive into some stuff that I know is going to be an interest to our audience about what you bring to this healthcare economics lens that we're talking about as well.
Yeah. So on the national scope, I'm going to pull that string a little bit here, is I got involved by doing the podcast on just kind of research and data, kind of getting that communication out there. And it just kind of snowballed into just avid activism within the national EMS sphere. And I got onto the board of the National Association of EMS Physicians, and just this past year, I got elected as the Secretary-Treasurer.
Congrats.
Thank you, of the National Association of EMS Physicians, which is an organization that empowers our physicians and our EMS professionals to practice medicine in the field. And essentially, now I'm on track to become the president-elect, president, immediate past president. So I have the next kind of 8 years kind of scripted out for me. What is interesting about that whole national sphere of my life is when I got elected, Dr. Ritu Sani, he was the president when I first got involved with NAEMSP. And Dr. Sani came up to me and said, Phil, congratulations on your election. You're going to be joining a select few of physicians who get to wear this and lead the organization. And he said, I have one other thing to say to you. He goes, I was really thinking about it on the flight over to this conference where I was talking to Matt. And he said, well, I realize you are the first EMS physician of the next generation to take the keys to the organization. And I'm cleaning up the language, but he goes, don't mess up. Right? But I took that very seriously because I was like, I guess I am the next generation, which it is a large responsibility. It's scary, it's anxiety provoking, but it's also very exciting because we get to set the vision for where we want EMS to go. And that's a very hopeful vision because I know a lot of EMS physicians of my generation who are so passionate about the field and are going to do some great things with what we're doing in the future.
So to that point, I want to kind of pivot to the topic that I really want to talk to you about. And this, Dr. Moy, is about the healthcare economics. Dr. Cozy, on a previous podcast that I did with him, gave me an aha moment. And I've been talking to you guys for a while, and it didn't hit. You know how sometimes you're talking to something, all of a sudden it hits? Yeah. And he was saying, Asbel, we go through about 12 years, 13 years of residency. We do our schooling. We do our intern. And he said, never once did they ever teach us about the healthcare economics of things. He said, I had to go back and get my master's degree in it. He said, there's some that have mentors that take them through the healthcare economics of things. He said, but never once did they focus. We got great clinicians, great things, but they don't understand the marriage of how the finance piece actually drives how you are able to do medicine because it is a business.
Right.
Healthcare is a business.
Right.
And so let's go down that aspect of it because that's what you've talked about at our Clarity Summit, talked about it from the eyes of the physician, what you think needs to happen in the reform. I'm not asking for people to agree with you or not. I want to understand from the physician's perspective that understands healthcare economics, how can the system of EMS be changed from your perspective? Because right now it just pays for transport.
Right.
Generally speaking, anecdotally, there's some, but generally speaking, it just pays for transport. Talk to me about that.
Yeah, as I mentioned in my talk in your Clarity Summit, there is we have to start with the foundation, right? The foundation of EMS, as Dr. Cozy mentioned in your podcast, it started with that 1966 white paper by the National Academy of Sciences, Accidental Death and Disability in the United States, which basically said, if you got injured in the field in the Korean or Vietnam War, you had a higher chance of survival than if you got injured outside the hospital in the United States of America. And we need to change that. And it was a phenomenal movement by our federal government to say, yes, we are going to serve our citizens and bring them to the hospital. And so that's why EMS is under the Department of Transportation. And it is at that point that I believe we've defined and we've answered the question, healthcare, equity, and literacy and access to healthcare is a right. We said every American citizen, anybody who's within our borders is allowed to get healthcare. We will transport you to the hospital. That's been answered as far as that whole action has been taken there, right? But what happened there is EMS evolved into not only you call, we haul, that's all. EMS evolved into a healthcare clinician who can treat, diagnose, or suspect certain pathologies and improve outcomes for our patients down the field. And so this may be radical. I know a lot of EMS clinicians have been screaming this at the top of the hill, but we need to get EMS out of the Department of Transportation and into the Health and Human Services sector of our federal government, right? We need that action to recognize our EMS clinicians as healthcare clinicians. And then we can have a Department of Transportation Advisory Committee, as opposed to what we have right now. We have the Department of Transportation owning EMS, and you have the NAEMSP, National EMS Advisory Committee, providing some healthcare information to the Department of Transportation. I think it should be flip-flop.
So you'd invert it.
I'd invert it. I'd put EMS under the Health and Human Services.
Okay.
And yes, transportation is a part of EMS, but that isn't the only thing that EMS does. EMS is a healthcare entity that provides healthcare for our patients, right? That is probably, if we can do that major pivot, that would be a huge change in how EMS practices medicine. And not only that, it will financially support what EMS can do in the field, which is what I've alluded to in the future. So I apologize, I went a little bit off script there. But yeah.
I actually, this needs to be heard.
Yeah.
This is coming from the physician's perspective. You're not the first person that I've heard say that, or the first physician. I'm recapping a conversation here that was on a podcast that we're doing in the special edition series with Dr. Lisa Graybear.
Yeah.
And she's a healthcare economist. She knows all about a lot of the systems. And she talked about an idea that she had for the industry around the prospective payment system, because this has been something that several of the MedPAC commissioners, doctors, they just could not understand how EMS providers were being called out to go treat someone, and if they did not get transported, they did not get paid.
Right.
And it just is like a hard core, like that should not be. And so maybe the system needs to be changed and evolved. And you saying this, like you didn't even know about this conversation, or none of this has been scripted, that your idea of saying we might just need to invert that doesn't mean that transportation or DOT is not needed. It just might need to be in a different position that it currently is.
Right. No, you're absolutely right. And as I said in my talk there, a little anecdotal story is I'm a medical director for our flight service as well as ground services. And I just did a podcast episode on my flight service flying to the scene where this poor young gentleman was in a car accident, got really messed up, broken ribs all over the place, pneumothorax, which is a collapsed lung. And if that air just keeps on trickling in there, that lung can that air can push over all your organs, and bad stuff can happen with you. You could die. And the ground EMS crew got him out of the vehicle, did interventions like putting a needle in his chest to kind of decompress that air that's filling up his chest to allow his lung to kind of re-expand. And by the time my flight crew landed, that pneumothorax had reaccumulated. They kept on putting needles in him, and they're like, this is not working. This isn't solving the problem. So my air crews had to do something called a finger thoracostomy, where they cut open into the chest and give a bigger hole for the decompression of the lung to happen so it doesn't squish your heart and you die, right? The flight crew took that patient and flew him to the hospital. That ground crew did not transport that patient. So their reimbursement is what? Because if all EMS does is just transport a patient, I guess the helicopter service gets reimbursed and not the ground service. That's just crazy. That just makes no sense. I mean, yes, we are adrenaline junkies. We're in emergency medicine. We're in EMS. Sure, that is what gives us our bread and butter, but we need some financial livelihood to continue to serve the communities that we do.
This episode is sponsored by Solutions Group Services, healthcare leaders' go-to source for maximizing reimbursement and inspiring innovation. At Solutions Group Services, Our technology and consulting expertise help organizations recover millions in hidden revenue without disrupting their workflow. Through our flagship AI-powered tech product, Black Ink, we reveal the dollars stuck in insurance claims and give you the map to get them back. Because for healthcare leaders, they know leaving money on the table isn't an option for their organization. Learn more at solutionsgroup.com and discoverblackink.com.
Well, it's as the Catholic Charities had no margin, no mission. And I just found this interesting, regardless if I'm talking to individuals on the Republican side of the aisle or on the Democrat side of the aisle, they all agree that there should be some form of payment to healthcare providers when they are seeing Medicare beneficiaries and others. Now, there has been, payers, which is a small percentage, anecdotally picking things up like this, but it's anecdotal. It's not a general uniform process.
That's correct.
And generally speaking, we've got to look at this in the context of how the system is made. So thank you for bringing that up. I
no problem.
appreciate what you're doing from the physician's perspective on making that happen. There's a few other things that I want to talk about.
Yeah.
And I want to talk about in your perspective from the uninsured. So you talked about earlier that we talked about, generally speaking, if you're within the walls or the confines of the United States of America, I'm not going to say walls, but in the boundaries of the United States of America, that generally if you need emergency assistance or 911, we treat you regardless if you're able to pay, regardless if you're a citizen. It doesn't really matter. We are going to help you and treat you. So that brings in the uninsured component of healthcare. And because of being an EMS physician, which is a subspecialty of being an emergency physician,
that's correct,
which I love. I love that we're doing. I think it needs to get more notoriety around here. And I'm hoping that you guys at the National EMS physicians continue to do that. And I'm going to do whatever I can to get out there, because it is I am convinced now. You guys have convinced me and I'm on your bandwagon. Does that make sense?
Yes.
So let's talk about access. Let's talk about the uninsured. Let's talk about how that looks, because EMS cannot function without the oversight of you.
Right.
Of the physician community. So let's talk about that in your mind's eye, and how do we correlate that from the physician community? How do we continue to take care of the uninsured? Because of course they can't pay. So there needs to be, we've got to do something about that. I have my ideas, but I just want to understand from the physician's
No.
community.
I think there's going to be a variety of ideas, and we don't know how this is all going to shape out, but this is a valid variable to consider for healthcare. So in general, from an emergency physician, we have an unfunded mandate called EMTALA, where we will see you no matter race, creed, or your ability to pay when you come to the emergency department, right? It's unfounded. We don't get paid no matter what, right? If you're uninsured, it's a write-off, right? But I think a lot of emergency physicians, I would say a vast majority of them, wear that as a badge of pride, because it's our job. I don't care if you can pay or not. You come to me, I will treat you as if you're my own mother, father, brother, sister. That's my job. But you're right. This is a margins, missions kind of discussion to have, and it's very difficult. And I would say that when you have to talk about the uninsured, you have to talk about the cost of omission, and the fact that if we avoid the cost of an ounce of prevention, and we say, well, we're just going to make it up in the cost of the pound of cure, right? That's often at the price of 10 times an ICU stay. Being reactive is so much more expensive than being proactive. And I think there needs to be something to support the uninsured to kind of prevent that reactive component that we have currently going on. I see every single shift, you ask any emergency physician, any EMS clinician, they see uninsured people who let their chronic disease go crazy, and now they have a much bigger problem and the horse is out of the barn. And all we can do as clinicians is try to corral that horse, but we're not going to be able to put that horse back in the barn. It's very difficult to do.
And I think that that's what this administration is looking at doing. This is why Secretary Kennedy issued out a FACA committee to put together kind of a group of clinicians and physicians and people in the industry to modernize the healthcare system, because you're exactly correct. people are sometimes not getting the treatment that they need until it's too late.
Right. Yeah.
And that's what you're talking about. I'm calling it that we need to be thinking about this from an EMS perspective on having kind of an EMS sustainability fund that continues to sustain EMS in those areas that can provide these proactive solutions that you talked about earlier. Moving from reactive medicine to proactive medicine. I think there's stuff that we're going to talk about, and I'm going to have you on here again because I want to get about the AI and how physicians think about AI and how that's going to move in here. But Dr. Beck is here as well and kind of talking through some of the information because they're beginning to see it in the longitudinal data of things that are transpiring when you look at the entirety of the healthcare record from the EMS side. That is beginning to show other certain things that if we do it differently, it doesn't need a transport, it doesn't need a 911 call, it doesn't need an ER stay, it doesn't need an inpatient visit. It could all happen. And this is something the industry has been talking about. But I get concerned because we keep talking the same playbook over and over again that we don't have the physicians leading that narrative.
Yeah.
Dr. Moy, I'm going to end it on this. I'm going to ask you one more question. A lot of people have asked me, Asbel, why are you getting more of the physicians involved now? I've been doing this for 20 years, Dr. Moy, and I've been advocating for certain things, and we're advocating for certain things that I advocated back in 2011 and 2012. Literally the same playbook.
Yeah, I understand.
And there was something that the physicians did a few years ago. And I think Dr. Kramer was involved in this. I think Dr. Antevi was involved in this. And this was around blood on the units. And CMS took a look at it and said, you know what? We can maybe make some of this the equivalency of the ALS-2 payment. There's some other things that happened in the reimbursement because they just didn't have the right healthcare finance people in the room. But I digress there, folks.
We won't comment on that.
We won't comment on that. But what I did notice is when the physicians got together and began to talk about this through the eyes of the patient and why this was going to be helpful to them, things moved. And the physicians know their patients that they serve. And I can walk into a room with a white coat and I can say the exact same thing that I've been saying for 5 years and they will start listening to the white coat. And I'm okay with that.
Yeah.
And so because now that you're involved in the EMS Physicians Association, you're kind of moving through there.
Yeah.
In your mind, it doesn't have to be right or wrong. I just want to understand where Dr. Moy is thinking.
Yeah.
Because I think if we can work this through, we can get people in the rooms that understand the healthcare economics, and we can get us moving in the right rooms. We can be designing the menu versus we can be at the table designing the menu versus being on the menu.
Right.
Eating from the menu. So tell me in the next year, what do you think? What are one or two things that you as a physician leader do you believe that you could do to impact the healthcare economics argument that we've been having for over 20 years now as an industry?
Yeah. So what I'd like to see as the first new president of the next generation is, yes, and this is a call to arms for all my physician colleagues as well, is we have a lot of confidence in our practice of medicine, but when it comes to anything else, like a little bit outside our little sphere of medicine, we get a little unconfident, a little insecure. And I do not want you to feel that at all, physicians, because we physicians live in this space between macro policy and micro reality, right? We see the human costs of macro policy every day when we practice medicine, right? And we also have the responsibility to our patients to help those policymakers understand that this isn't a zero-sum game versus cost versus care. This needs to be pivoted into value-based outcomes, and who better to understand financial and align financial incentives with long-term outcomes than a physician who understands the research, what medicines work, what medicines don't work, right? Yes, you may not have an MBA or be as financially knowledgeable as Asbel here or anything like that, but you have a core experience and a core knowledge and a wealth of information that can give credence to our patients and serve our patients in the best way possible. So that's what I would really like to see as my colleagues take that step forward. Because I get it. There is that sphere of insecurity once you step a little outside that medicine, right? Medicine politics, medicine finance, right? That's a little unsteady, but you need to realize that you know it. Everybody feels a little insecure, but you got this, and we can make a big difference. We just have to be willing to make that step, and I'm calling on you guys to really push forward and just take that first step.
And thank you, Dr. Moy, for saying that and calling that and speaking to the physicians that are listening to this right now.
Yeah.
Because there are people like us, me in particular, that I'm moving away from being I want to be a guide, because you guys need to be at the table, and there's a reason why we're having this. Like, I cannot keep executing the same playbook thinking I'm going to get a different result.
Right.
That's insanity at that point. I don't care if I change the color of the book. I can change the color of everything that goes on. But if the same content and structure is still the same, it's the same playbook. Right. And so we've got to get you guys there, and we need to make sure that area of insecurity that you may not know, the healthcare economics, the healthcare finance side of it, there's some of us that know it. We'll train you on it.
Right.
I'd love...
Or you could guide us.
Guide you guys on that, because you guys are powerful in number to understand. So I'm going to end with this.
Yeah.
One thing that keeps Dr. Moy up at night.
My kids. No. I would say, Hope, I was really thinking about a question like this about the future, especially with my impending presidency coming up. And I get this feeling of butterflies in my stomach, right? And I'm an endurance athlete. I do a lot of triathlons. And it's the same sort of feeling I have when I'm training for a race, when I start a race. The goal is to get to the finish line. But that triathlon, that half Ironman, 70.3 miles, it's a long way, right? So you have to have that ability to see what's in front of you, but also see far ahead of you. And so what keeps me up is really the hope that we will get through this really rough patch we are in healthcare today, be it healthcare finance, be it the moral injury of what we're dealing with as a result of healthcare finance and what's going on in this country. But I'm encouraged because I have a lot of colleagues who are passionate about their patients, passionate about what's doing best for them. And I know that the only way you can lose the Ironman race is it's a death by a million cuts if you just stop running. The goal is to just keep on going one step at a time. And the goal is to get those butterflies that I'm feeling that are keeping me up at night, and to get those butterflies to fly in formation. That's the goal.
I love it. Doctor, I'm going to end it here. Thank you so much for joining me on the Leadership Lab.
It's a pleasure.
And I'm so glad to see physicians like you in the forefront leading us through the next transformation of healthcare.
Well, thanks, Asbel, for having me on, and I really appreciate it. And thank you for having me on the Clarity Summit. I appreciate it.
And we will do this again. Thank you very much for joining us.
Cheers.
Bye.